Good afternoon, everyone. Welcome to our Pedi ECMO webinar on novel extracorporeal anticoagulation. For next slide, this is a reminder to our Pedi ECMO YouTube page, where you can access the recording webinars using the QR code that is on the right. We'll share it again at the end of the presentation. We do not have any disclosures, and you can get some CME after the webinar. We're going to share again another QR code for that. My name is Sonia Laberinas. I'm one of the cardiac intensivists at University of Texas, Houston. I'm going to be one of the moderators with Vari.
Hi, folks. Thanks for joining us. Vari Karam, I'm one of the cardiac intensivists and ECMO medical director at Children's Los Angeles, and we're excited to have this.
Thanks a lot for our panelists that accepted our invitation for our webinar. So today we have the pleasure to receive Dr. Brock, who works at the University of Alabama, and then Dr. Brogan, who works at Seattle Children's Hospital, and Dr. Karam, who works at Yale School of Medicine. So we're going to start with Dr. Brock and a little bit of discussion about nitric oxide. So Dr. Brock, you published about your institution's experience using nitric oxide in the ECMO sweep in your pediatric cardiac ICU. Why was this practice instituted?
Yeah, so it was, first of all, thanks for having me. I'm excited about this. So it was a kind of a theory that we as a group had entertained for quite some time. And we had a patient who was post-cardiotomy who had a lot more of an inflammatory response to ECMO than what we typically see. And so we felt that this would be a good patient to start it on. After starting it, we were able to, the inflammatory response seemed to improve. We were eventually able to wean the child off of ECMO, and that was our index patient. And over the course of the next couple of years, it became more of an institutional practice for us to put nitric oxide into the membrane oxygenator after that.
Thanks so much. That's really interesting. And now I'm going to ask all panelists, what are the potential benefits, in your opinion, of adding nitric oxide to sweep gas flow?
Huh. I'm a little, I don't really know, because there was a study, a pilot study that was done a few years ago that evaluated specifically this, and they showed no real benefit, nor on the oxygenator, or on bleeding or clotting. So I'm trying to square my mind around the results of your study, Al, but then putting this in the context of then an RCT that sure was not, the sample size wasn't for it was just a pilot, but I'm still struggling to sort of say, well, should we all be doing this, or because it's expensive, right? Like it costs $100 an hour to do this, so it's like you're nearly doubling the cost of ECMO every single day that you're doing this. So I'm curious about the real benefits of this.
I would agree with Oliver that we don't have enough data to really speak clearly about this. So to say something, I will say things that are essentially related to my personal experience, so anecdotal. And as somebody once said, anecdotes is not the plural of datum, but we have used it frequently when we either have to turn off our anticoagulation or turn it way down, or when we've had a circuit that looks bad and we've wanted to try to limp that circuit along as long as we could. I've talked with Giles Peake, who is the senior author on that paper, a lot about this, and I swear, and again, this is anecdotal, but I have seen kids with dirty circuits actually improve on nitric. It doesn't entirely make sense to me mechanistically, but I've seen that in several cases, and it does seem like we've been able to get away with lower levels of the other anticoagulants that we use. In our case, it's usually bivalve, but and it works. So again, this is in the realm of religion, and I don't mean to cast aspersions on religion, but I think there's not enough data, and it would need to be looked at on a larger scale. But in the kids that we've had bad looking circuits, or in whom we've had to stop anticoagulation for whatever reason, it seems like it's helped. But again, that's a judgment call, and it is indeed expensive.
Thanks a lot, Dr. Brogan and Dr. Karam. Now back to Dr. Brock. Can you describe, please, the anticoagulation and the nitric oxide protocol outlined in your review? And my understanding is that you used it for every ECMO patient.
Yeah, once it became part of our protocol, we used it in everybody. So at baseline, all of the patients in the study were anticoagulated with bivalve. That was an institutional change that happened in probably 2017 or so. So predated this study by, or this patient population by a couple of years. And then once within a couple of hours of going on ECMO, we typically would put in nitric oxide into the sweep gas, and then we would typically run it at no less than 1.5 liter flow, and then bleed in CO2 into the circuit to maintain the CO2 physiologic, or the pH normal in those patients.
And so everybody understand, what were the main findings of your study?
Yeah, the main findings of the study, I think, were essentially that it's safe. One of the main concerns I think that we all had was that the levels of met hemoglobin would be high. Especially, it's our practice that we use sodium nitroprusside as our first line vasodilator. Our study did show that the baseline or the median met hemoglobin levels were significantly higher statistically. But clinically, it wasn't a difference. The difference was 1.6 versus 1.1. We showed there was no statistically significant difference in overall blood product usage and overall duration of the circuit. But clinically, the circuits were lasting about almost twice as long as what they were prior in the SNO cohort compared to those that were not on SNO. And the blood product usage was, depending on which one, platelets were 30% less, and overall blood product usage was 10% less. So while not statistically significant, maybe clinically significant. And there was no clinically significant met hemoglobinemia in any of the patients.
Sonia, can I just ask another question to Alan? Because you said something that is quite interesting, and I don't know how many sites do this routinely, because you said that your flow is always at 1.5 liters per minute, right?
Yeah.
And so how old was your population? What was their median weight? Just because I'm trying to think what proportion of your patients were at 100, and that's fine, or what proportion were in fact at 200 and you bleed in a lot of CO2 to keep, like, how are we doing that? Or are you talking about the sweep that was at 1.5?
The sweep was at 1.5 in order to deliver.
The flow didn't change, correct?
Right, yes. And I would say probably about the most I saw of bleed in CO2 was 75, and the large majority were between 25 and 50. I mean, it's really hard to dial in to know exactly what amount of CO2 you're putting in, but it was never an exorbitant amount.
Yeah, that helps, yeah, because I was just thinking about the clotting in the oxygenator that could be flow dependent,
Yeah.
but it has nothing to do with the CO2. So that's helpful. Thank you.
Mhm.
So I have a question for Dr. Brogan, because Karam already took his turn. Dr. Karam already took his turn. What risks do you think there are by administering nitric oxide? Like now listening to the results of the study of Dr. Brock.
Well, our experience has been that it's relatively safe, and just as Dr. Brock has described, we haven't seen any evidence of concerning methemoglobinemia in these patients. We run and this is how we do. We run it at 20 parts per million at whatever the sweep gas flow is, and that we base on usually on our CO2 goals, and so the concentration is the same, but the amount delivered to the oxygenator will be a function of how fast the sweep flow is. The thing about nitric is that it gets bound rather rapidly in the bloodstream. So once it gets into it has some local effect, but I think by the time it actually gets out of the oxygenator, there's very little effect. So we haven't seen any hemodynamic effects from starting it. And we also, similarly, you wouldn't get a benefit of maybe some right ventricular afterload reduction because by the time it gets back to the patient, it's pretty much inactivated. So I think it's relatively safe. I think, again, the biggest downside is that it's expensive. And in our institution, it's managed by the respiratory therapy team, and it makes the director's budget a little bit out of whack. So she's usually unhappy with us about that.
Thanks a lot, Dr. Brogan. And Dr. Karam, so there was some evidence showing reduced circuit changes rate in ECMO patients receiving nitric. Do you believe we should change our anticoagulation strategies? Or do you think in the case you would add nitric oxide, it should be added as an adjunct to your anticoagulant? Did you hear my question?
Yeah. Personally, I tend to first, I would like to do no harm. And so I'm glad that from a safety perspective, this seems safe. Then I do want to have a benefit for my patients, especially if the financial cost is high. And so I would like to see a large randomized trial on this before I really implement it at the bedside. But I'm already happy that it doesn't seem to harm patients.
Thanks very much. So in conclusion, I think everybody agrees that there will be a benefit of doing a big randomized trial with nitric and anticoagulation. So I think you answered all my questions, but I don't know if someone has questions on the chat or if there are any other questions among.
I do think that we have one chat question. It is, how soon is nitric oxide placed into the circuit? And that's from Ebony Grady.
Yeah, so I'm now at the University of Alabama, Birmingham, and we also do the same thing here, putting nitric oxide in all of the ECMO circuits, and it's done within the first hour, typically, of going on ECMO, so pretty quick.
I have a question, Elise. Twofold, actually. This is Jamie. I'm from University of Louisville. I've met a lot of you guys today, and this is such a strong group of people to be learning from. I have two questions. One, I'm gonna not speak to it well enough, but my manager's on here, so hopefully he's listening and he can help me. But when we tried to roll this out here, theoretically at first, we tested it in like an in situ lab first with our ECMO circuit and I believe it's the Vero nitric delivery system. And we found that when we were looking at the amount of like the sweep gas in the delivery and actually looking at the flow, that if we were less than 0.5 of sweep, we were unable to accurately know the measurements because of the way that the inline filter, like from the nitric test it. It would almost, oh my gosh, I wish Brad would, or if he's listening, maybe he can speak up. I'm gonna mess this up here. But basically,
I'm here.
Okay, so explain what we found, Brad.
Yeah, so we found that the sample line averaged about 0.3 mLs of sample. So between 0.3 and 0.5 of sweep, we actually had retrograde flow through our oxygenator. So we were entraining room air and going backwards to the sample line.
And
if that makes sense.
yeah, and we, we don't add CO2 at all. So that's like one, I know everybody kind of does this uniquely and differently. And so we decided, like, for the first patients to try it on, we would make sure that their sweep requirement was at least greater than 0.5 because of what we found. And I didn't know if anybody had any other thoughts on this. We've only done this twice now, and they were both in cardiac ICU patients, and they were both already bleeding patients. And so we haven't found that it's been of any benefit per se. However, anecdotally, I will say these patients received a lot of blood products and went a very long time without the need for a circuit change. And so, on the other hand, maybe anecdotally, it did make a difference.
Dr. Brock or Dr. Brogan, I'm not sure if you guys have noticed the same thing that they did.
Or Dr. Brock, is that why your institution had a sweep minimum because of delivery?
Yeah, that was kind of the theory. We didn't do any wet lab trials like that, but that was part of the reason why we left the sweep gas, the flow at 1.5 and just bled in CO2 was out of concern of buildup and the patient not getting what we thought they were getting.
We don't use that nitric system, so we haven't run into that issue. And it was tested by our respiratory team before we used it. But I don't know how low. That's a good question. I don't know how low they ultimately went on the sweep flow rate.
I think that's an important question, though, because if you're going to use this, in the patients that you're going to, we theoretically think it might help the most. I tend to think those are some of the patients that are higher risk of bleeding. And those patients often have pretty healthy lungs going on and require very low sweep gas.
Yeah, Jamie, I think that's the question that's also being asked in the chat, and so I'll just raise it for folks. And is one of the questions before we switch away from talking about nitric oxide is this what is the right dose, and is a dose dependent on the pathology? So if we have patients who are in circuit DIC or on for sepsis, is there potentially any evidence that helps us say that those patients would benefit with this adjunctive anticoagulation because of thromboembolism or anti-inflammatory effect? And would that be a different dose than those who are on with healthy lungs for cardiac reasons? Or do we have any evidence to help us delineate dosing?
Wow, that's a very interesting question. And in fact, part of the problem is that we use 20, which is based on what we do with the ventilator. But, back in the day, Warren Zapol never did a dose response curve. And a lot of people, myself included, think that, at least in the ventilator, a lot of the effects of nitric are actually between 0 and 1 part per million rather than between 1 and 20. So what you need for platelet antiplatelet effect is, it's not clear to me. I don't know, maybe Alan or Oliver knows.
Yeah, I mean, that's a question I have too. It's not it would be great to know what dose, and in what particular population it might be the most beneficial, but I don't know of anything that suggests that at this point. So we just use the same standard dose we used on the ventilator.
I'm always wary of nitric oxide because we wrote the Cochrane a few years ago. And in both adult and pediatrics, there is an increase in patients with ARDS. So not looking at pulmonary hypertension, but in patients with ARDS, when you give nitric oxide to the ventilated patient with ARDS, you do not change any clinical outcomes. Yes, you change the saturation of the FiO2 for up to 48 hours, but then the both arms go back together. But the only outcome that you do see, so you don't see changing length of mechanical ventilation, length of stay, length of anything. The only thing that you see is a tripling of renal failure. And that to me was very interesting. And I think that when we give nitric oxide to some of our patients, we mess with the ability of the kidneys to micromanage their perfusion because we just vasodilate that. And so I'm always also wary in these situations where we give nitric oxide to a patient who is on ECMO and quite frequently do not have great kidneys to start with. I'm always also worried about this. So I'm glad that it wasn't found in the observational studies. But to me, that is, if we do one day a large RCT, I absolutely think that we also need to think about looking at the incidence of AKI in these patients. And I don't know, to answer the question about the dose, I don't know the dose in here.
I think we've got a couple questions actually directed to you, Dr. Brock, about your study in the chat as well. One from a little bit earlier was if you could review the primary goals of your study, like was it improvement in clotting, adverse effects, or anything else? And then assessment or safety of the side effects of nitric if added to the circuit for any reason. That was one part of the question. And they were also commenting that isn't the risk of methemoglobinemia pretty low with the newer machines that are out there.
Yep.
So that was one question. And then I think Natalie Rentoul has brought up some other points about asking specifically like what pump and oxygenator were used in y'all's study.
Yeah. So with such a small sample size, I mean, obviously we wanted to look at some of the clinical benefits of it, but with the small sample size, we didn't feel like we could really achieve that. So one of the questions that always got brought up, at least initially, and why it took really almost 2 years to get everybody in our group on board to trial this, was the concern of safety. And yes, I personally, I mean, I haven't been practicing medicine for very long, but I have never seen a case of methemoglobinemia, and you have to go back a long ways to find where some of these things cause clinically significant methemoglobin. And even when I changed institutions here, I had at UAB, some people, when they would see a methemoglobin of 2, would consider stopping the nitric oxide into the circuit. So that's really what we looked at primarily, and then just looking at secondarily, blood product utilization to see if there was a difference in survival, difference in circuit life as surrogates of a clinical benefit. As far as what circuits we used, Centromag, Pedi Mag were in a large majority of the patients using initially the Quadrox until oxygenator. Until those were no longer available, and then switching to a Euroset. And then the Euroset was based on the size of the patient. We used all 3 oxygenator sizes, the neonate, the pediatric, and the adult, depending on the size. And then there were a small percentage of the patients that were on a CardioHelp system. And then, yes, there are, one of the other comments was about doing a prospective randomized control trial with Dr. Peak. And that's something that we've definitely discussed or have been discussing for a couple of years now.
Thanks very much, everyone. Oh, is there another question?
There's another question that just popped up. It was a great discussion. I love it. So for Dr. Karam, for your ARDS nitric study with increased AKI in the nitric group, did you look at nitric breakdown products, or are you attributing the increased AKI to the vasodilation secondary to nitric? Did that group have lower blood pressure or need more pressors?
So that's a great question. Since it was a Cochrane review, it was a systematic review of and meta-analysis of multiple ones. So this is just combining data. You don't get to the granularity of really understanding the physiology behind it. So no, I do not know if it is linked to the nitric oxide breakdown or if it is just from the vasodilation. The impression is that it is linked to vasodilation just from a physiology standpoint, but I don't really know, and it wasn't linked to a decrease in blood pressure because that was not seen across the studies.
Dr. Brock, I wonder if I could direct that question to your sample size. Did you happen in your study, were you able to see nitroprusside utilization for your nitric oxide patients? Like if you typically use nitroprusside, were you using less in the patients who received the sweet nitric oxide?
That's not anything. I didn't collect that data. So I mean, I would say subjectively or anecdotally, there wasn't a difference, but that's just me speculating.
I have to say that I think from a hemodynamic physiologic standpoint, I think the use of nitric oxide is really not associated with changes in blood pressure, even when you're just using it in the ventilator. Again, it binds avidly. I think it's now I'm forgetting the number, but it binds very avidly to hemoglobin and other serum proteins. So it gets neutralized very quickly. So it essentially it diffuses across the pulmonary membrane when you're putting it through the ventilator, and it diffuses through the oxygenator when you're putting it through your ECMO circuit, and rapidly gets inactivated. So I would suspect, although I certainly don't know this, but again, nitric oxide is a precursor for other nitrites and nitrates. So I would suspect that if there was injury to the kidney, it's related to an oxidative injury standpoint more than a hemodynamic physiologic standpoint. But again, that's just me thinking. I don't have proof of that. But we never have to change our drips when we start nitric. So anyway, that's been my experience over the years. But I agree that with Dr. Karam, that in the vast majority of ARDS patients, it doesn't do anything. So if you turn it on and you don't get a response within literally minutes, you should just turn it off. Although there are a small number of patients who have astounding responses to it. But I would also say that you should probably, if we're talking about ARDS, you should probably prone your patients before you start nitric, because that has been shown to improve. And if Dr. Gattinoni were still around, he would tell you that that is the absolute best way to help your ventilation strategy without having any hemodynamic effects. And he knows a lot more than I do.
What a robust nitric oxide discussion. Thank you so much for that. And now we'll go to the second half of this novel anticoagulation discussion and talk about prostacyclins and prostaglandins. So to kick this off, and as we switch gears just a bit, I'm going to direct this first question to Dr. Karam. You recently partook in a systematic review, which we are excited to hear about. So systematic review and meta-analysis of prostacyclin-based anticoagulation strategies, and you can see the title and citation on the screen for you all. Would you please give us a summary and the major takeaways of this review?
I had managed to mute myself on Zoom after 5 years. First, I'd just like to do a huge shout out to Neda, who is an intensivist in Saudi Arabia. And she reached out to me now a few years ago saying, hey, I've heard about your research that you do at Pedi ECMO. I'd like to do a study with you. And I'm interested in prostacyclin. And I'm like, yeah, let's do this. So this is the first part of that, of the research program that we have developed with her. And so it's fascinating to see how these sort of webinars that we're doing now are really building collaboration around the world. So our question here was, people seem to be using prostaglandins in various situations where they want an anticoagulation effect. And so we were going into this looking for studies that had evaluated prostacyclin in extracorporeal support. And so we were hoping to find ECMO studies and CRT studies and MARS studies. What we sadly found was that there were no studies on ECMO using prostacyclin, which is PGI2. We did find all other studies that were there, the 17 studies, if I remember well, that were looking at prostacyclin on CRT. One of them was CRT plus the MARS support, so the liver replacement, but that's fixed on a CRT device. So they were all CRT studies. None of them prostacyclin were ECMO. What we found is that it prolongs the duration of a filter. It doesn't lead to more clots, but it decreases the number of bleeding events in critically ill children on CRT. And so it was an interesting signal to look for. It is interesting also that currently there is a citrate shortage in many places. And so I've already heard people reaching out about saying, well, I'm starting to do prostacyclin in my CRT since it is so difficult to do regional anticoagulation anymore. So it's really interesting to see how these things morph into different projects and were very timely. I'm not sure that, well, that was a very long answer, Mary. I'm sorry.
No, please don't apologize. And I think it's important for us to tie all of our extracorporeal technologies together when we're looking at data and seeing how it can apply to our patient population. So, so thank you for that. And so then let me ask, let me shift to, there's recently this VV ECMO RCT that was published looking at the use of prostaglandins, showing fewer circuit clots, fewer bleeding events, and no adverse events. Do you have comments on that, or would any of the panelists like to add to that?
So I think this was a fascinating study. So it is on prostaglandin E1, so alprostadil, that an Austrian group randomized on their patients on ECMO. It was VV ECMO in adults, right? So I don't think that it can be completely transposed to children, but it was interesting to see that they did this, and they did this, they started in 2016 and finished in 2021. And so they randomized a total of 50 patients, 48 in the end that ended up being in each group. So 24 in each group for a total of 48. And what they showed was that they had fewer clots. They had a longer clot-free time, so time until the first clot. They also had fewer bleeding events and a longer time until the first bleeding event. And so to me, it was really fascinating to see how it was just an add-on to the regular anticoagulation, which they were all giving unfractionated heparin, so they weren't doing bivalve at the time there. And so you got heparin, and then you just add PGE1, and you decrease significantly the bleeding events and the clotting events. And to me, this was, because it's an RCT, I think that it avoids a lot of the potential confounders in observational studies. And so to me, this was really fascinating, because each time we do research on clotting and bleeding, you always worry that if you have fewer clotting events, then you're going to have more bleeding events, or the other way around. And so to finding both clotting and bleeding lower, to me, was pretty significant. And I'd love to do this down the road in pediatrics.
Yeah, I mean, I'm actually very interested in prostacyclin on ECMO. We at UAB, within the last 3 months or so, have started doing low dose epoprostenol for our CRT, given the citrate shortage. And I don't have any data to support it, but anecdotally, it seems to be doing its job and serving well. I think anecdotally, the handful of patients that I've cared for on ECMO, whether they were on epoprostenol for pulmonary hypertension, or whether they were on prostaglandin for ductal patency, have all seemed to have pretty smooth ECMO runs from a circuit standpoint. So that's kind of, I never really thought about it very much until recently, as that potentially being a cause, but it's something I'm very interested in starting here soon.
Dr. Karam, I've looked at this paper, but I couldn't find it. Do you know what the monitoring was for the unfractionated heparin in this study?
So it's a good question. I just put a reference in the chat with the DOI. Let me look at how they were managing this.
So just the reason why I'm asking is because we used to use heparin. We don't use heparin anymore, but we switched from ACT to anti-10A, and we noticed the exact same outcomes as this study did, just by switching the monitoring. I think now I will say beforehand that Dr. Bartlett does not agree with me, and I've done this long enough to know that disagreeing with Dr. Bartlett is usually not a good thing to do, or at least you do it at your own peril. But I will say that our experience has been that anti-10A is a much better test for monitoring heparin. You end up using, you have less changes in your heparin dose, you have fewer circuit changes, you have less bleeding and less clotting. But now we use bivalve, and I think that's even better. And we can talk about that later if people want. But so it would be interesting to know how they monitor, because also APTT is a terrible test as well. And I'm happy to speak negatively about PTT for as long as people like as well. But and I will add before I shut up, the third point is that we have started to use prostacyclin in kids who have ARDS, who have essentially complete whiteout or mostly complete whiteout when they're starting to have RV dysfunction or elevated pulmonary pressures, to try to unload the right ventricle. And thus far, our anecdotal experience is that it seems to help. So you might actually get a benefit of right ventricular afterload reduction by using, and we use low dose, we use between 2 and 8 nanograms per kilo per minute of the prostacyclin. And one of our fellows is working on writing it up. And we use that precisely because if your lungs are whited out, the nitric is not going to do anything.
I love that. I can't agree more that APTT or ACT shouldn't be the target. We published another systematic review showing that in the RCTs that were comparing both, you had a real decrease in bleeding by 50% in the groups that were targeting an anti-10A, and no increase in bleeding, in clotting. So decreased bleeding, no increase in clotting in another systematic review. So I can't agree more with you. To answer your question, so what they did, it was they started with a bolus of heparin immediately after ECMO cannulation, 50 units per kilo. And then they followed the APTT for a goal of 50 to 60 and or, so we don't know, and or anti-10A of 0.2 to 0.3. So quite low anti-10A goals, lower than the average of the ELSO guidelines, which are 0.4 to 0.6. So they were anticoagulating on the lower side. And it's interesting to see that maybe at least some of it has to do with the decreased clotting. Maybe it's because of that, but it's hard to explain the decreased bleeding too.
Matt Malone, who is at the GREAT program in Little Rock, said that they've seen more clotting of their circuits with prostacyclin. And
sorry, that's just in CRT. We haven't made it
okay.
Jump to ECMO. Just we're using that with the citrate shortage for our CRT machines, and we've had much more frequent filter death or shorter life, I guess, since we've made that switch, unfortunately.
We haven't seen that, but I will add, there's one question which I'm happy to address if the chairs would like me to do so about the PTT. But I will also say that when we switched to APTT, once things are stable, we went to Q6-hour monitoring. So we decreased costs a lot by drawing less blood and by doing fewer tests on the blood. So there.
Thanks for that. Let's talk about PTT, but not yet. Let's do a little bit more discussion around prostacyclin, and then I think we can talk about multimodal anticoagulation sort of in a couple more questions, and bring up the PTT question and bring that back. Can I just, for the panelists, because there's been a little bit of back and forth in dosing, and it's not in the chat yet, but I would presume that's what we all have the same question is even though it's based on anecdotal experience, what doses are we using when we're anticoagulating or adjuncting our anticoagulation with prostacyclin?
I mean, I tend to follow the CRT stuff, and we start at 4, and after 30 minutes, if there's no high potential, we go to 8 and leave it there.
Yeah, that I think is the most frequent dose that we found in the systematic review, and in the study of not prostacyclin but alprostadil on ECMO, they started so PGE1. They started at 5 nanograms per kilo per minute. So we're not comparing oranges to oranges, but it's on the lower side of the doses, lower than what you'd expect for vasodilation, for example.
Yeah, that would be like 0.005, which is a low dose, very low dose.
This is something, just as a side note, Larry, this is something that we're trying to explore further now. So we are writing the proposal to query the FIS data set to understand how many people use both either prostacyclin or alprostadil on ECMO. The most frequent indication is going to be pulmonary hypertension, but it would be interesting adjusting for pulmonary hypertension if we can see a difference in signal in some of the outcomes. FIS isn't the perfect data set to do this because you don't have different lab results. You don't have all of the bleeding outcomes the way we'd love them to. But at least we're going to have like something like 14,000 ECMO runs. So that might be answering some of it in an easy way, even if it's still completely observational and prone to biases.
Yeah, thank you for that. Has any of the panelists used prostacyclin-based anticoagulation as a sole anticoagulant in any of their experiences, whether it's on CRT or in another capacity?
Yeah, I think like a lot of people seem to have said, because of the problems with citrate, we do in some of our CRT patients use just prostacyclin.
And have you noticed anecdotally a difference in bleeding complications that have been published a little bit of recently, or not enough population to be able to comment on that?
We don't have a lot of bleeding with our CRT patients, so I would be speaking a little bit out of turn, I think.
I must say that I would be very concerned to use only prostaglandin-based anticoagulation on ECMO. I think that, yes, it's a great adjunct to affect the platelet function. It is frequently something that we don't really address on ECMO. We do it much more on VADs, but less on ECMO. And so I think that it is a good adjunct. I would be like, we'd have to do animal models and things like that to see how safe it is to only do that, I'd say.
Yeah, thank you for saying that. And that also answers the question that's up on our slides. And so Dr. Brock and Dr. Brogan, if you would like to add to that, how should we use prostacyclin-based anticoagulation in caring for our ECMO patients?
I can't really add much to what Dr. Karam said. Again, we've used it in the setting of RV dysfunction or concerns about the right ventricle. We haven't used it as we hasn't really used it as an adjunct. Our experience with BiVal has been very good, and when we need an adjunct, we usually use inhaled nitric. And again, that may not be the right thing to do, but that's what we've done.
Yeah, I mean, for us, what I would like to do is kind of the same, carry over the CRT dosing and use it as an adjunct to BiVal. We have recently switched over here in Birmingham from heparin to BiVal for our ECMO, and it's been a little bit of a challenge coming from a center that only used BiVal for the last 6 or 7 years. Has been a very difficult transition. So, I think as an adjunct for sure. Have never had the experience of using solo and would be very hesitant to use it solo unless I had to.
Thank you for your opinions on that. I think that that raises the question that I think we can sort of tie back to the PTT questions from the chat, which is when we're exploring multimodal anticoagulation approaches, what do you think are the advantages of multimodal anticoagulation, and how do we balance the data that we're getting in? And then Dr. Brogan, I open up the PTT discussion for you to feel free to comment on also.
So I would like to say that this is all my brilliance, but in point of fact, we had a guy here named Wayne Chandler who did a lot of this work, and he understood the system better than any other human being I've spoken to in my life. So all of this is basically, I'm just regurgitating what he's taught me. So PTT is a test that is affected by a number of things, including your factor, the amount of factor that you have in your blood. It's also affected by heparin, obviously, and it's affected by circulating inhibitors, which are very common in critically ill patients. So if you look at people's baseline PTT, some are normal and some are abnormal. So if you have an abnormal, he's shown that if you have an abnormal baseline PTT, your dose response curve with heparin or bivalirudin for that matter is really, really unpredictable. So you can correct for that. He's published a paper. You can correct for that by giving protamine to try to get rid of the heparin and get a sense of what your baseline PTT is on a patient who's on ECMO. So baseline doesn't mean your PTT before you start ECMO. It's your PTT at that moment without heparin on board. And then if you look at the scattergram of PTT versus heparin dose or anti-10A, it's really not very good. So it's really in my opinion, again, by what Dr. Chandler showed me, it doesn't work very well. So you're basing your anticoagulation on a test that is affected by a lot of things that's happening and that change over time. Now, your PT gives you a good idea of how much coagulation factor you have on board. So that can be a helpful adjunct, but again, it still doesn't tell you. And then one of the things, we've switched to bivalirudin for a number of reasons. And the test that we use to follow it is based on something called a diluted thrombin time. And so Dr. Chandler was able to create a test for us that gives us essentially the concentration of bival in the blood, and it's very easy to use and works very well. And a number of labs have adopted that with his help. A few labs have tried to create a bival level based on the PTT, which is a mistake. That will not be a good test. You might as well just follow the PTT. The other thing that is very interesting is that in about a third of babies and in some older patients, there is a negative dose response curve with PTT and bival. So as you go up on your bival, your PTT actually goes down. So it's for all those reasons that I think the PTT is not a good test. I think the anti-10A, again, Wayne publishes these data. The anti-10A is much more stable. You have fewer circuit changes, less bleeding, less clotting, and it's less expensive. So all the things you'd like. So if you're going to use heparin, and I'm not telling you not to, because there's a lot of experience with heparin in our community, and it's been around since J. McDonald discovered it more than 100 years ago. That's great, but I would say PTT is not a great test. It's also definitely not a great test for bival levels.
Dr. Brogan and all the panelists, so for bival anticoagulation, what are you using for treatment monitoring?
So again, we use a bival level, which is a assay that's based on the diluted thrombin time. And again, Dr. Chandler published a paper or several papers on how to do that. You basically set up an assay, you dilute the plasma, and you measure a diluted thrombin time. And then you can calibrate it so that you get the levels you want. And so in our ECMO patients we don't have a bleeding concern, our levels are 1 to 2. And basically I think it's microgram per mil. And then with a Berlin or another mechanical circulatory support, we go up to 2.5. And then if we have bleeding concerns, we lower that. So in ECMO patients, it's 0.5 to 1. Nabiha Sadiq, who was on earlier, and if people want, I can connect you with her. She can help you get this set up. And the lab people should be able to do this. It's apparently, if you're a lab person, it's a relatively straightforward test. So that's what we use. Although initially when we go on, we also follow PTT for the first 6 hours to make sure that things stabilize, which is, again, you could say, but you're saying that doesn't work, which is true, but that's what we do because we're human and we're not perfect. And then after about 6 hours, we go to Q6 hour testing, and the dose levels are really stable. It's a great thing.
Thank you. Dr. Brock or Dr. Karam, do you want to add to anything or do anything differently?
Yeah, we don't have the ability to do dilute thrombin times here for a variety of reasons. So we strictly follow PTTs, and then we also try to correlate it with an R time on the TEG, although it's, as everybody has mentioned already, it's not the best test in the world. Neither test is perfect. And so using a combination of the two. I have used heparin absorbed PTTs in the past, and felt like that those provided were a little bit more reliable than PTTs. But again, that's not something that everybody can do.
Thank you. And Dr. Karam?
So we don't have either the ability to do a DTI here at Yale, so we use a PTT. There is very little evidence to suggest the clinical benefit of DTI. So there's the correlation is fantastic. If you look at really you measure it with mass spectrometry, the concentration of bivalirudin, and you do a DTI, it's extremely well correlated. If you do a PTT, it's just a big cloud with a very poor correlation. Most of the studies are 0.08 from an R. But there are very few studies that have shown if you are supratherapeutic, if you're in the therapeutic range, and if you are infratherapeutic, how many clotting events do you have? Because if you would imagine that if you're supratherapeutic, you would bleed more and you would clot less. No, the other way around. You would, yes, bleed more, clot less. And if you're or sub-therapeutic, you would clot more, bleed less. And in fact, there isn't a very good correlation. And this has just been, to my knowledge, there's just one study that has been done in all comers, adults hospitalized on bivalve, but not specifically on ECMO. And so I'm really interested in sort of thinking how you would be like, is there a dose response relationship with bleeding and clotting the other way around, or is it just all over the place? So I don't know. I'm intellectually, I would like to use the DTI, but I don't know.
So again, I would say if those studies are following PTT, they're just showing that PTT is a bad test. And that, as I said, which is a little bit hard to swallow, but Wayne showed me the data. In about a third of patients, especially when the bivalve level is high, you actually have a negative dose response curve. So if you increase your bivalve dose and measure the level, you have a decrease in your PTT. So it would make sense to me actually that you might have more bleeding at a lower PTT if the bivalve is at the high level of the therapeutic range or supratherapeutic. So that's why, I remember many years ago, one of our pathologists, and this was before Wayne was here, said, "Why don't you just turn the heparin on and leave it at 20 and see what happens?" And I think that there's a little bit of wisdom to that, because I think if you're not using the right test, you respond to the wrong data. I think, ACTs are really problematic, in my opinion, as well, for monitoring heparin. But again, Dr. Bartlett, if he were here, would firmly disagree with me. And so anyway, but I think that your monitoring is the thing that's going to determine whether you use the anticoagulation correctly or incorrectly.
Thank you so much for this really lively discussion. I think that we have so many things we could talk about and keep going, but for the interest of time, I'll sort of wrap up our discussion here. There's lots of questions in the chat about tags and utilization, and I think we could have a full hour on that. So I apologize that we haven't fully been able to get to those questions. I think you did hear Dr. Brock talk about our time on the tag and seeing if that's helpful, and then a little bit of a discussion on that. And so, so thank you for all of the really interesting points that have been brought up, excuse me. And so I think what we'll do next is sort of close out. And so again, the attendance code is available for you on this chat here. And then, as you guys know, and we hope you can join us in the future, there's quarterly education, and we really like to tailor this to either new information that's coming out or based on the feedback that we receive through this QR code. So please give us feedback and let us know what else you'd love to learn about. And thank you so much, Drs. Brogan, Brock, and Karam, for your expertise in this material.
Thanks for having us.
Yeah, thank you.
Thank you.